We'd like to thank you for joining us this morning for our Coffee, Kids, and Sports Medicine series. I'm Dr. Shane Miller with Scottish Rite Sports Medicine, and I'm going to be speaking this morning on the evaluation and management of sport-related concussion. I have no relevant financial relationships or disclosures for this talk. Today we're going to summarize the new evidence-based guidelines on outpatient concussion evaluation, and then we're going to move into outpatient concussion management, including return to play and return to learn guidelines. And then we'll focus on identifying patients who may require referral to a sports medicine specialist or concussion specialist for further management. So our case for this morning is a 10-year-old male who presents for evaluation in the pediatric setting following an injury that occurred 2 hours prior while at football practice.
Still stopping.
Go, go!
Oh my gosh.
So as you can see here, you have two young boys lined up approximately 10 yards apart, running full speed at each other with, I suppose, hoping for a good outcome in that situation. But unfortunately, this young man came out on the wrong end of that. I see about four parents standing around, not parents, coaches standing around and helping, who think that may be a good idea. So this young man has now come home after practice, and his mother notes that he did not have any loss of consciousness, but that he seemed dazed and out of it when he came home from practice, and he was complaining about a headache, said his stomach hurt, and he was a little bit dizzy. So we have several questions that come to mind. This young man presents to us for evaluation. One question that we get a lot from families is, how bad was this? What grade is the concussion? And do I need to take him to the emergency department? Sometimes that may be on the sideline. We're at a game, covering a game, and making that determination whether somebody needs to be transported and taken to the emergency department. But commonly, they may be calling, asking for questions either via telephone or telemedicine triage, or presenting in your clinic and asking, do they need to be taken in? And one of the reasons that we may send them would be if they need neuroimaging. And so is neuroimaging indicated in this case? And when can he go back to school? And the question that I get most commonly from my families, even after I've gone through the rest of these, is when can he go back to football? Or when can she go back to whatever sport it is that they're participating in? That may be their priority when I'm focused more on their injury itself and their recovery. So when we're looking at the numbers of concussions, we're talking about a huge problem. This is millions of cases per year of sport-related concussions in the United States alone, and those are ones that are presenting to the emergency department. So there's likely a big number that's underreported, and or some that are presenting that we may not be able to track. So looking at a recent study from 2019 of high school concussion rates, we're looking at, of course, football we all think of as number one, but a close second would be girls soccer. And girls tend to have a higher rate than boys in comparable sports. So when you look at girls soccer, our incidence there is 8.2, which again, football is at 10.4. So now boys soccer, 3.6. So girls almost more than twice as high of an incidence compared to boys soccer. When we look at girls basketball, 4.9. It's the same as boys lacrosse. But yet, boys basketball, 2.1. Again, over twice as many incidence rates in the girls' concussions in comparable sports. So I think that we tend to focus on football, and even my case this morning is a football player, and we're in Texas, but I'll tell you that nationally, and certainly here locally in the North Texas region, in my clinic and our clinic here at Scottish Rite, girls soccer is a close second to football, and we certainly see almost as many girls soccer players as we do football players with concussions. So certainly we do not want to neglect that population when we're studying, thinking about especially programs to help mitigate or prevent concussions. We need to not lose sight of the fact that there's a lot of other children that are getting injured besides just football players. So a concussion, of course, is a brain injury, and I tend to use those words intentionally. I want families to understand that this is an injury to the brain, and it's something that we need to take seriously. Very commonly there are some injuries or some things that we may allow continued participation despite a little bit of discomfort, but a concussion is one of those that we take seriously and need to evaluate more thoroughly and make sure that they're fully healed before they get back into their sports. Typically, to concuss means to shake, So when there is a blow, typically to the head, but sometimes to the body itself, the brain will shake inside of the skull, and that's what causes the concussion. This is an injury that causes impairment in function. The way that the brain typically functions is impaired or altered by the concussive injury. A concussion currently is not diagnosed on a standard CT or MRI. The vast majority of our standard routine imaging is going to look for a more significant injury, an intracranial hemorrhage or skull fracture, but there are some research-based imaging modalities that may be able to detect some of the changes related to a concussive injury, but it's not required and actually not typically helpful in a concussion to get a standard CT or MRI. I think a misconception that's been fairly dispelled is that you do not have to get knocked out to have had a concussion. The vast majority of patients don't lose consciousness when they sustain a concussion. The symptoms can be broken down into different categories, and we're going to get a little bit later on, and when we're discussing management, some of the newer concepts of clinical profiles and how a lot of these may overlap. So we certainly don't see a patient only have cognitive symptoms or only have physical or emotional symptoms, only have sleep symptoms, but oftentimes they will have overlapping symptoms from several different areas. But these are sort of the main categories where we may notice symptoms, and symptoms are certainly important, and it's hard for us as clinicians to evaluate what the patient is experiencing, so we have to ask. We have to ask them what symptoms they're having, and certainly with children and teenagers, if I ask them, how are you feeling? I tend to get an answer sort of along the lines of fine, or okay, or good. That's about all I'm going to get out of them. And so we do recommend using validated symptom scales as we're assessing these. And we'll talk about that briefly here in a minute, but making sure that you are asking these questions so that you actually make them think about different symptoms. Otherwise, they may not think to tell you that being a little tired is something that they're experiencing, and it may be related to their concussion, and they may not put that together. So I mentioned the question of, what grade is this concussion? How bad is concussion? Those of us that have been practicing for more than a few years recall that we have historically graded concussions. And so here are several different historical classifications, the CAN-2, the Colorado Medical Society, the American Academy of Neurology societies. Well, we've abandoned all of those, so don't try to memorize those. We're not using those anymore. We're no longer grading concussions, so when the family asks you what grade is this concussion, then we're not able to do that, and we're not able to tell how bad the injury is until a patient has fully recovered. Somebody may seem fairly mildly impaired and may take months to recover, and that may be a more significant injury than somebody who seemed to be more injured early on, but yet recovered within a matter of a few days and seemed to have no long-term sequelae related to that injury. So currently, we are no longer grading concussions and have not been for a while. Some of the more recent guidelines that we follow tend to come from this International Concussion Conference statement, and where there's this group, they meet every 4 to 5 years or so, and they review all of the latest literature and the latest evidence that's come out in the interim with concussions, and then we'll write this consensus statement. And again, this is typically sort of expert opinion based on the latest literature. And so the most recent one was published in 2017, where they convened in 2016 in Berlin. And so we refer to that as the concussion consensus statement, or the fifth International Conference on Concussion in Sport consensus statement. They were scheduled to have their next meeting this year, but now it's been bumped back until next year. So if anybody is looking to go to Paris, October 2021, and so they are also accepting abstracts, and so research that's up to date. Those of us in the concussion research world, this is a good, potentially get some of your research accepted there and have it incorporated into the next consensus statement. So that probably expect that in 2022 will be our sixth statement. So for the next couple of years, we're relying on the fifth statement. Additionally, there are several other groups that have come out with more recent guidelines that we will review today. The CDC came out with guidelines on prevention guideline on the diagnosis and management of mild traumatic brain injury among children in 2018. The American Academy of Pediatrics came out with sport-related concussion in children and adolescents. That's an update on their previous clinical report as well. And the American Medical Society for Sports Medicine came out with their position statement on concussion in sport. And so it is important to make sure that we're looking at all of these because they may differ slightly, but a lot of the information contained overlaps and is similar among the different guidelines. And so I will review and highlight the most important areas that I think for pediatric practitioners and providers to understand. So thinking a little bit about some of what we do is based on those guidelines, and all of those have come out in the past couple of years and tend to be evidence-based and up-to-date current guidelines. But we also have legislation, laws that may govern how we practice medicine and how we manage concussions that impact us. So this question, how many states have a concussion law? So think about what your thoughts and answer might be there, and I'll move forward here. So in 2009, Zachary Lystat's the young man there pictured with his parents, where the first law came into place and was signed into law in the state of Washington based on Zachary's history as a young man who had an injury during a football game and was allowed to return to play or continue playing after his initial injury and sustained a second blow to his head and came off the field with a catastrophic injury and is still to this day significantly neurologically impaired related to the injury. And so Zachary's family and many lawmakers in that state felt that if there had been perhaps proper education on how to respond, and Zachary had been removed from play at the time of his first injury and managed properly, that he would have recovered uneventfully and maybe not have had this potentially second injury, which is sometimes referred to as second impact syndrome. And so they have been huge advocates for this and passed that law in 2009. Texas surprisingly followed not long after in 2011 with what's known as Natasha's Law. There's a picture there of Natasha Helmick. She's a young lady that was a soccer player here in the North Texas area at Allen High School, then went on to a career at Texas State University as a collegiate soccer player, but her career was ended short, unfortunately for her, due to her multiple concussions and the sequelae of that. So she has also been an advocate in our state. And so we've had a law here for almost a decade managing in legislating how we manage concussions that also impact some of the things we do. And so I recently had an experience. I work with several local school districts in terms of developing, as part of this law, where we have what's called a concussion oversight team to help develop the concussion protocols for each local district. And unfortunately, sometimes the law takes precedent over evidence in terms of the school's administration's ability to adapt some of the newer recommendations that the medical world may have because the law has not been updated in 10 years. And of course, they have to follow what the law and the regulations are. So sometimes there's a little bit of a discrepancy between what the law may say and the evidence-based medicine that we may be seeing, because this develops very quickly. So 2009, as I mentioned, Washington. 2010, 11, a lot of states came on board, 12, 13, and by 2014, all 50 states have had a law. So this is not new. We have all had laws in our state for a while now, and so depending on where you are, if you're not in the Texas region, you need to be familiar with your law because it may vary on who can return to play. And so a lot of them require some component of education, return to play, and medical clearance. So, all right, so we've decided that we're not going to grade his concussion, and now we have to kind of make some decisions about what we're going to do. So what should be done in the event of a suspected concussion? So especially if we are there as a parent or a spectator or as a medical professional covering an event, some of our athletic trainers, of course, are covering these frequently, but as physicians, sometimes we're also on the sidelines. And so one of the take-home phrases that I like to use is, when in doubt, sit them out and keep them out. Anytime that an athlete has signs or symptoms of a concussion, I do think it's important to immediately remove them from play and keep them out until they've been thoroughly evaluated, properly evaluated, and we're certain that they either don't have a concussion and are safe to return, or they have had a concussion and have fully recovered and have gone through some of our criteria to be cleared to return to play. We will commonly see patients that come into clinic and have continued to play or have returned to play after their injury. It's a significant number. It's approaching 50%. Actually, of the patients that we see report that they continued to play after their injury. And so we clearly still have a lot of work to do in terms of the culture among athletes, coaches, and a lot of times well-meaning coaches will sort of ask an athlete, how are you doing? Are you okay? Are you good? And, and what's the athlete going to say? Well, of course I'm good, coach. I'm good to go. I'm ready to go back in. And so then the coach goes, allows the athlete to go back in. And this happens at all levels and ages and sexes. So, we see it commonly in soccer on the sidelines, just a weekend coach and will say, hey, are you good? And then they go back in, they finish the game, and then their recovery may be impacted by that. They may feel worse and take longer to recover. And then certainly we don't want them to sustain a more significant injury, such as Zachary Lystep. So remove them from play, ensure they're evaluated, and if parents are not there, it is very important for the parents to be informed. Parents like to know what's going on with their children, and keep them out of play the same day. When I was in training, even as a resident, we were returning athletes to high school games the same day if we felt like their symptoms had subsided, and that was based on previous criteria and guidelines at the time, but we're no longer doing that. Even at the professional sports levels, in the NFL, if somebody has a concussion, they do not go back the same day, so no same-day return to play. So when do they need to go to the emergency department? That was one of our questions about this young man in our case presentation, is does he need to go to the emergency department? So we're typically looking for red flags, something that seems to be laying out a slightly different scenario or picture than a standard concussion. In general, most concussions do not need to be evaluated in the emergency department. I think that they can be evaluated in an appropriate setting by somebody who has confidence and experience and knowledge in regarding concussions and can be sent home. But red flags may indicate something significant or different is going on, and so I've listed some of those. The ones on the left come from some of our documents that I discussed, and specifically looking at weakness or tingling in the arms or legs. I think a lot of it is looking for more neurologic symptoms and or worsening symptoms. So you talk about progressively increasing headache, where we're worried about a hematoma, and so in terms of loss of consciousness, not everybody that's lost consciousness needs to go to the emergency department. I think a brief loss of consciousness, again, although less common, is not particularly concerning, but a prolonged loss of consciousness, so maybe greater than 60 seconds or a minute. Again, deteriorating level of consciousness, they're worsening, repeated episodes of vomiting, if they're combative, or if they're continuing to have seizures or convulsions, all of those clearly may indicate something more significant going on and require imaging. I think that one of the big points of emphasis from all of these guidelines that have come out is trying to limit the amount of unnecessary imaging procedures, and particularly unnecessary radiation in a pediatric patient. And so a lot of them are stating to do not routinely image pediatric patients to diagnose a mild traumatic brain injury. As we said, it's typically not helpful. It's not going to give us much information and should only be used in certain criteria. And so following something such as the PCARN criteria, which is a validated clinical decision rule to help determine who has a higher risk of a clinically important TBI, meaning something we might do something about, find something on imaging, and would be a better candidate to have imaging ordered. And I think those are very helpful to follow that. The evaluation is thorough. The brain is complex, and so everybody may be affected in different ways. Symptoms may present in different ways. And so you want to get a good history about the injury and what happened. Then, as I mentioned, the symptom scale, I think, is very useful both at the time of the injury and, of course, in follow-up to assess their recovery or lack thereof. We can compare their progress. And so there are several different symptom scales that I have mentioned there that have been validated. And I don't think it matters exactly which one you're using as long as you are using one. And you just need to be consistent with that. So whether you're using the post-concussion symptom scale or the graded symptom checklist, the SCAT-5 is great too. And I have a picture there of the SCAT-5, and we'll talk a minute. There are both adult and pediatric versions of that. The child SCAT-5 being ages 5 to 12, and the SCAT-5 being older than that. And but it has symptom scales on there. And so that is nice that you have that, and that can be done by the patient prior to entering the exam room, so you don't have to spend as much time going through that, and then they can have completed that for you. Of course, a thorough physical and neurologic examination. I like to include a balance assessment. I think that is one of the aspects of the brain that we can assess a little bit more objectively, and we like to assess that. We also look at the vision and the vestibular ocular motor screen, or the VOMS test. And then you want to perform some sort of neurocognitive testing, looking again at different aspects of the brain's function there. So I mentioned the SCAT-5. This does include some of those. It includes the symptom scale, includes the cognitive assessment, and includes a balance and gait examination. This is just the 5th edition, which is why it's called the 5. Each time they come out with a new consensus statement from the group, we're on the 5th consensus statement, so it's the SCAT-5. And so this is showing you those, comparing the SCAT-5 to the child SCAT-5 there, and they're slightly different in terms of the symptoms and some of the cognitive testing. So for example, the SCAT-5 may ask an older child or teenager to recite the months of the year backwards, starting with December, versus a younger child, we may ask them to do the days of the week backwards. Just slightly changed a little bit there based on developmental expectations. So it does include some balance testing, particularly incorporates what's called the BESS, the Balance Error Scoring System. And this is a series of 3 tests you can see here, both with feet together, eyes closed, hands on her hips, and stands for 20 seconds. And we're assessing essentially the number of errors that are made, either opening their eyes, taking the hand off the hip, having to step out to catch their balance. And then they do it on one foot, and then they do it with tandem stance, one foot in front of the other. So 3 tests, 20 seconds each, and we count the number of errors. And so if sometimes it's helpful to have a baseline so we know what's normal for that athlete. But even if not, we can get a pretty good guess. So for example, a highly skilled, junior and high school athlete who's very athletic should probably have decent balance. And if they can't stand on one foot for 2 seconds with their eyes closed without having to put it down, then that's probably abnormal. Here is an example of a young man that we saw in clinic. You could see a couple days after the injury, first with feet together, just the double leg stance, and now he's doing the single leg stance, and he's unable to maintain single leg stance initially after the injury, is having to sway quite a bit and having to put his foot down. And then a couple weeks later, his balance had significantly improved. So we do see changes there. As part of the exam, we'll also follow the vestibular ocular motor screening, or the VOMS, and this incorporates several different areas of assessing the eyes. I think that we're trying to gain information that allows us to put pieces of the puzzle together to make better assessments and to make better treatment plans for the patient. And so this one starts with smooth pursuits, and then we do horizontal and vertical saccades. We will also do near point convergence, as well as the vestibular ocular reflex, or gaze stabilization, both horizontal and vertical gaze stabilization. As well as visual motion sensitivity testing. And so there are handouts and documents out there that can kind of take you through how to perform each one of these. They're not super complex, but the gist of it is that we are looking at primarily to see if symptoms worsen with this, and or to see if we can elicit nystagmus or other abnormalities in terms of their speed or their ability to focus on a target or an object. And so both from a injury as well as a returning to school and a returning to sport perspective, this information may be helpful or useful for us. So this young man here initially is coming in. We're just performing smooth pursuits here. So as our finger is moving gently back and forth across the screen, you can see he's having a hard time. His eyes keep coming back to midline even though our finger is not. He's blinking quite a bit, having a hard time focusing. And his eyes are actually tearing up a little bit. And when we ask him, he says, it makes me very dizzy and makes my head hurt. It makes my eyes hurt, makes my head hurt, and it makes me dizzy doing that. 2 weeks later now, so very smooth, normal movements. He's following the finger, smooth, able to focus, does not cause any symptoms. And so clearly there's been some change there, and he is recovering from his injury. But additionally, when I evaluate a patient like he was soon after his injury, not only is he not ready to go back to his sport, but he may struggle going back to school. If I try to send him to school and ask him to read and or go into class and look down to take notes and look up at the board where the teacher is presenting on the smart board or on the chalkboard, if his eyes can't follow my finger gently moving through the office without causing that type of a response and those symptoms, he's going to struggle making it through the school day, and we're going to not understand, well, why can't he make it through second period each time he's going to the nurse's office and they're sending him home before second period. And so maybe if we make a subtle change and say, all right, let's have you go and listen, and let's have somebody give you the notes so you're not focusing as much on reading and taking notes because your eyes are not working well and they're causing you symptoms, but you may still be able to go and be in class and make it through the full school day and listen and learn and absorb the material that's being taught that's new, so you're no longer falling further behind and you're learning and getting caught up without feeling worse, without prolonging your recovery, without having to be sent home from school. And so sometimes we'll find these, and then sometimes it may be that they're telling us that they're ready to go back, and maybe on that symptom scale that I was telling you how important I think it is, the athlete is going to try to fool us, and they're going to come in and put all zeros on that. I'm fine, doc. I have no problems at all. And then you pick up on something like this and you say, okay, they're clearly not ready to go back out on the field. And so we do utilize this information. So I think the balance and the vision are two of the things that I would like you to incorporate into your exam if you're not already doing that, in addition to some of the symptoms as part of your sort of global assessment. We do utilize neurocognitive testing. As I mentioned, some of that can be done through a SCAT-5, sort of like a mini mental status exam, looking at orientation, concentration, memory. There are also computerized versions of these. These are based on sort of pencil and paper neuropsychological testing or neurocognitive testing that's performed. And so these are a couple of brands of computerized neurocognitive testing. Impact is one that you've heard or you may have heard of. When people say, I'm going to take an impact test, and that is, again, it's just a brand of a computerized neurocognitive test. It is one that's commonly used in the North Texas region, so you may see it or hear it here a lot. A lot of the schools will utilize that as baseline and or return to sport criteria. But it's essentially a 30-minute test that looks at the brain's function, memory, working memory, reaction time, et cetera. I think it is important that we don't utilize this as our only criteria for return to play and or whether or not they had a concussion, because you can have a patient who has a concussion who does perform quite well on the testing, and so you cannot utilize that to say, you have not had a concussion, or vice versa. And so I think it's not the only tool to be used. Even some of my neuropsychology colleagues who I know manage a lot of concussions, they also have sort of, this has sort of fallen out of favor in their perspective too, as more data comes out. So it is something that we utilize, but I would say it's one additional tool that we utilize in addition to balance and vision and symptoms and putting everything together to make our assessment, as opposed to utilizing this as our sort of pass-fail. But unfortunately, sometimes in the community, this is still either marketed or perceived to be a one-stop shop that will get you everything that you need. There is a pediatric version now for ages 5 to 12, sort of like there's a SCAT child version, there's an impact pediatric version that's performed on the iPad, so slightly different, again, more developmentally appropriate for the younger children. So From some of the more recent guidelines, they say computerized neurocognitive testing may add incrementally to the identification of clinical impairment within 24 hours of injury or within a short time period after symptom resolution, but do not add significant value over symptom assessment later. So again, it comes back to what I was saying. It should be used as only part of a comprehensive concussion strategy and should not be used in isolation. So when we are managing these, one of the take-home things messages that has changed in the past few years is we have shifted from, now it's been a little longer than that. I was going to say about a little over a decade ago, as I mentioned, we were returning athletes to play on the same day. And then there was a shift to where we went from doing that to saying complete rest and complete physical and cognitive rest until they are asymptomatic. In no school, no sports, turning off the lights, taking away the phone, turning off the TV until their symptoms resolve. And now there's been a shift back to sort of more of this focus on symptom-limited activity. Basically, whatever they can tolerate that doesn't make them feel worse is probably safe and beneficial. And so we'll talk a little bit more about that as we go through this. But when you take a teenager and they have an injury, or maybe they don't have an injury, you take a normal teenager and you take them out of their sport that they love, you take them out of school and away from their friends, and you take away their phone, it's not going to go well. Even in the exam room, they don't want to be apart from their phone for 30 seconds while I'm examining them. So you can't imagine what happens when you take their phone away from them. The children who are really concussed and don't feel well, they don't want to be on their phone right then anyway because it makes them feel worse. But the children who have mild symptoms and it doesn't bother them much, it's probably okay for them to have their phone. Now, I don't want them to be on it for 4 hours and just texting nonstop. I don't think that's a great idea anyway. But that tends to be their social device, their communication with the outside world and their friends. And when they lose that, we may be actually sort of causing iatrogenic symptoms and prolonging the recovery in some of these patients by demanding strict rest requirements, either from restriction from electronics and or school or physical activity. So we do want to get them back. This is sort of a summary slide of what we're going to talk about for the next few minutes. I do want to mention sleep in particular. I think a lot of times we talk about rest, but rest is different than sleep. And sleep is important. They need to be getting 9 to 10 hours of sleep a night. Most teenagers are not getting the recommended number of hours of sleep of 8 to 10 hours of sleep. And so I like them to get a little bit more when they're concussed, or at least to get that minimum that they should be getting that they normally are not, so that their brain can recover. We also like to think about driving restrictions, and some of our older kids, our juniors and seniors in high school, sometimes may get concussed at practice and then are allowed to drive home from practice. And so I do specifically mention that while they're concussed, I do not want them driving. Their reaction time, their cognitive processing skills may be impaired or delayed. And certainly we wouldn't want anybody being injured if they were to be involved in an accident or a collision on the road. So I do have them restricted if their exam or any symptoms are abnormal. So I mentioned earlier this concept of clinical profiles, and this is sort of an evolving concept but relatively new. As you can see here, we have areas broken down into different profiles. So there's more of a vestibular, a cognitive, fatigue, anxiety or mood, headache or migraine, and ocular profiles. And clearly there's a lot of overlap along those, but each of this kind of goes through what are the physical exam findings and what treatment you may want to consider based on where they primarily lay. And again, they may have more than one clinical profile, because you can see a lot of times they'll overlap a little bit, but it helps us in terms of individualizing our treatment plan and our management based on the response. I will oftentimes get questions from different providers. Do you have an algorithm on how you manage concussions or something along those lines? And that's probably the slide before this that talks about symptom-limited activity and kind of getting them back to physical and cognitive activity as tolerated. That's probably the algorithm, because everything else beyond that is so individualized based on their exam, based on their symptoms, based on their medical and psychological history, based on their sport, based on where they are in the school for the season, that it really is challenging to think about. But this clinical profiles is another layer to that helps us as clinicians think about what do we want to do to target our treatment for that specific patient, and based on what their profile may be. So, as I mentioned, cognitive rest is something that we used to think was significantly important. And although, early reductions in cognitive load and cognitive activity may be helpful, we don't want them to continue to push at 100% from the time of the injury. We want to let them back off a little bit, but they don't have to go to zero. And so there are some studies that looked at patients, and some they put into a strict rest group, and they found that those that were required to do strict rest had a longer recovery and higher symptom burdens than athletes who would just rest for a couple of days and then sort of return to activity as tolerated. Those who didn't reduce their cognitive load at all also took very long to improve, but even those who just took a little bit of reduction in their cognitive load resulted in similar recovery times. So I think the concept here is that we want to allow them to back off based on how they feel. So I will often ask them a percentage number of what percent of normal do you feel today? With 100% being normal pre-injury, where do you feel? And so if they're telling me 20%, well, they're not feeling very well. They're going to struggle. But they don't do 0% of their normal life. They can do probably 20% of their normal load. And then once they say, okay, I feel 80% of normal. Again, they're not back to normal. They're not ready to be doing everything normally in school and doing full load with full testing and everything, but they can probably do 80% of their normal coursework. And so oftentimes they'll start off at a low number and then progressively get better and better as their injury heals and they recover. And then you allow them to do a little bit more and a little bit more as they heal. We certainly will recommend using some sort of a return to learn program. And a lot of the schools in our area are becoming more familiar with this concept as they are treating a lot of their students who have sustained concussions, helping with this. But this is something that we do play a role in as pediatricians and specialists who are taking care of these. And based on the symptoms that the child is experiencing, based on their exam, we may recommend certain activity or academic adjustments. And if it becomes more prolonged, then sometimes that rolls into accommodations or 504 plans or IEPs. But again, most of the time in the first few weeks, a simple written document to say, hey, while they're recovering, let's make these adjustments based on their symptoms. And the schools tend to do a pretty good job of accepting that. And then as the child heals, then we can release those restrictions. This letter here that you see on this screen comes from the clinical report in pediatrics from 2013, Returning to Learning Following a Concussion. This is also being updated, and so maybe in the next year or so we'll have an updated version of this. But this is for free use, so you can certainly copy this and put your name and clinic name on there, and basically allows you just to check some boxes based on your recommendations. So fairly easy and not too time consuming. And so, again, as I was saying, we may want to modify things based on different symptoms. So, for example, if headache is one of their primary symptoms, they may need to take frequent breaks. They may need to go take a 10-minute break in the nurse's office or a quiet area and lay down for a little bit, depending on what is going on. So these are a few adjustments that may come from that help us individualize that management and the activity adjustments based on the child's symptoms. So not noise and light sensitivity, very common, difficulty concentrating, sleep issues. So some of those options. The CDC also has a version similar to the one that I showed you that the AAP had put out that's also fairly easy to use and is just, again, a lot of check boxes. So there are a lot of resources out there. I think it doesn't matter what you're using as long as you're using something that's easy for you. We understand the challenges of managing these patients. These are very time-consuming patient encounters. We allot more time than normal for these patients and spend a lot of time both at the time of the visit, educating the family and the child, but also after they've left. There's a lot of discussion, and interaction with the family with questions and follow-up questions as things evolve and as the symptoms improve. And so it can be very time-consuming. So anything that can help you minimize that is helpful. So I like some of these resources that are out there. When we're talking about physical activity, Again, there's been a shift. We used to have them completely shut down and say no physical activity until you're symptom-free. Well, it's normal to take 2 to 3 weeks for a teenager to recover from a concussion. It's normal. So a lot of times we'll get a question, somebody has been seen in the emergency department, 3 days later they're still having a headache, so they'll either bounce back to the emergency department or they'll go see their pediatrician. And that's very normal to have symptoms for 3 days later. Again, it's normal to have symptoms for several weeks. And so you can imagine if you have a child and tell them that they can't do any physical or cognitive activity till they're asymptomatic, well, 2 or 3 weeks is a long time to go. And so imagine how stressed you would be if you're behind in school, you haven't been in school, you have all of the makeup work, and not only do you have the makeup work, but you haven't learned the new material that was being taught for the past 3 weeks. You're going to be really behind when you go back. Same thing physical activity-wise, you're going to be deconditioned. There's a lot of benefits to exercise and physical activity in terms of mood and other pain relief and other aspects that we're not taking advantage of if we restrict them completely from physical activity early on. So this is just some highlights of data that has come out in the past few years. But forced exercise is not going to be helpful after concussion. So if somebody doesn't feel well, tell them to go get on a treadmill and push through their symptoms is probably not the right way to do it. But voluntary exercise is safe. Absolute rest beyond the first few days after concussion, however, may be harmful or detrimental to concussion recovery. So again, the first 2 to 3 days max, a little bit of reduction in cognitive and physical activity, and then we want to get them back to symptom-limited activity, what they can tolerate without making their symptoms worse, and start getting them back into things as tolerated. And then another one, physical activity within 7 days of acute injury compared with no physical activity was associated with a reduced risk of persistent post-concussive symptoms at 28 days. So not only do we think that it is safe, but beneficial. Early physical activity is beneficial. Another recent document from last year, early sub-threshold aerobic exercise. That sub-threshold is talking about where is the threshold that makes their symptoms worse, and exercising just below that. Same thing with cognitive activity. Find out how bad they are. Can they do 80% of normal? Well, then we probably want them at 70%. We don't want to put them at 85% if they can only tolerate at 80 without feeling worse. But we want to continue. And then as they get better, once they're up to 90, well, then you can bump up their activity level as they improve. But this one found they randomized children into 2 different groups, a stretching group and a light aerobic exercise group. And the stretching group was more likely to have delayed recovery. And so took the aerobic group recovered 4 days faster. So 13 days versus 17 days. But again, you're looking at that normal window. That's 2 weeks versus 2.5 weeks. So a normal recovery pattern for teenagers and through there. So again, some more evidence saying that early physical activity is probably not just safe, but beneficial and something that we would like to incorporate early on in our treatment of patients with a concussion. More data sort of supporting that. That was showing that stretching and aerobic exercise group and a Kaplan-Meier curve there. Okay, so both the AAP and the CDC have said initial reductions in physical and cognitive activity can be beneficial, but prolonged restrictions on physical exertion or removal from school can have negative effects on recovery and symptoms. So instead, we want to have them recommend. We want to make sure we're giving them instructions on returning to activity based on their symptoms, and no more than 2 to 3 days of rest. So we continue to see patients who will present to us that are 2 or 3 weeks into their injury and still have not returned to school, and because their treating provider has recommended that they're still having symptoms and that they not go back. And so one of the first things we do is we get them back in school, and so we want to get them back quickly and to non-sports activities, some physical activity as well. In our state, we talked a little bit earlier about Texas law, and it has been around since 2011, what we call Natasha's law. The law only applies in our state to essentially public schools, public middle school and high schools, UIL schools. It does not apply to private schools, does not apply to recreational or club sports. And so not every patient that we see is going to fall under this law, but for those that are in public schools, these are some of the components of the law. It does require immediate removal from play, which is consistent with what we've suggested from anybody. They should not go back the same day. They can't go back if they're having any symptoms, and they must complete a progressive return to play. One of the components of the law that's unique in our state is that it requires clearance by a physician. In Texas, a physician is defined as an MD or a DO. So that means that an athletic trainer, a chiropractor, a neuropsychologist, a nurse practitioner, or a PA are not allowed in our state by law to clear an athlete to return to sport participation, again, in the public schools. It doesn't apply to club sports or rec sports or private schools. But that is an important component to remember if you're managing patients in our state, to make sure that we're in compliance with the law. In general, not just with our law, we mentioned not going back until they're symptom-free and until they've completed a gradual progression. So just like when we're getting them back into school, progressively, we want to get them back into physical activity progressively. We want to make sure that their symptoms do not return with physical activity, and so in a safer environment. Here is one example of a gradual progression that you may follow. So stage 1 is that symptom-limited activity, and we start that almost immediately based on what they can do. Daily activities that do not provoke their symptoms, get them back into school activities. Once they're feeling better, then we'll get them back into more, sort of regimented return progression, which will be light aerobic exercise. And even the light aerobic exercise, that stage 1, I may have somebody on an exercise bike, a day after their injury. If their symptoms are fairly mild, and I see them Friday, and maybe Saturday they rest, or Sunday they're back on the bike. And so again, we're not having them do a spin class on the bike and really doing something super strenuous, but that sub-symptom threshold exercise we think is helpful. Just pumping a little bit of blood to the brain, getting that heart rate up a little bit is very helpful. Then we progress them back into sport-specific exercise, then into non-contact training drills, and then back into full contact training, and then back into their games or sport participation. So each one of these stages needs to take a minimum of 24 hours. So if I see somebody on Wednesday in clinic and clear them, so to speak, to return, they're not going to play in a game on Saturday. There's just not enough days to get all of these stages in for a weekend soccer tournament. And that's a common scenario. They come in, they want you to clear them to play in a tournament that weekend, and you have to explain to them that the importance of going through each one of these, even if they've been symptom-free for 2 weeks. If they haven't done any of this and haven't tested themselves out, we need to make sure that they can tolerate each one of these stages. And so at this time, the guidelines are 24 hours per stage, and you got to complete each one of these, and we're not going to skip it. It's just not worth it. We want to make sure that they can tolerate it and are safe to get back. So there are specific goals and objectives of each one of these stages that we want to evaluate and before we get them back out there. As far as sort of prolonged recovery goes, those who have had previous history of concussions, those who have underlying neurological or psychiatric disorders, we ask all of our patients when they come in for a concussion if they have a history of ADHD, dyslexia, learning difficulties. We ask them if they have a history of depression or anxiety, bipolar, because those things may impact their recovery. Older children and adolescents tend to take a little bit longer. Those in a lower socioeconomic status also may take a little bit longer, and sometimes that's access to resources or delayed presentation. Females also tend to take a little longer to recover. And those who present, when I see somebody who comes in and fills out our symptom scale and they're endorsing severe symptoms on every single one, when you walk in and they say they have 6 out of 6 vomiting, and you walk in, have you vomited? No. Have you vomited at all since this injury? No. But today you're having severe vomiting? Yes. So that's probably a risk factor for a prolonged recovery when their symptom severity is very high in multiple symptoms. So looking at that symptom scale is also helpful to us. If somebody comes in and they've circled, ones, very mild symptoms on only a few of the choices, then maybe they're going to recover fairly quickly. Referral criteria. I think that these are not set in stone. Using your clinical judgment is really probably the best time to refer. And when something is a little bit out of your comfort zone, or if it's something that you feel like is anything that you would like help with is very reasonable. Even as specialists, we commonly would consult with our team. So as a sports medicine doctor, I consult with my physical therapists, and they help a lot with some of these vestibular and balance issues, or perhaps we'll see that a child has a neck injury that's contributing to some of their symptoms, and they work with those a lot as well. We work with our neuropsychology colleagues. We work with the neurologists. There are a lot of different parts of the team that we work together, and so I think don't ever hesitate to reach out for help, especially the more complex injuries. But when somebody's taking longer to recover than you would expect, or they're not following that normal curve progression, you see them at the 2 days after the injury, and you see them back a week later, and they haven't improved, or perhaps they're a little bit worse. Maybe you don't need to wait a month until you send them on. Maybe that one is not following that normal recovery trajectory that you would expect, and is a good one to go ahead and refer on. If they have other risk factors, if they have a history of a chronic headache, they may be more likely to have exacerbated their headache disorder, and maybe struggling with headache symptoms. Anybody who has worsening symptoms that we don't have a good explanation for, if they went to a birthday party over the weekend and then didn't do so well the next day at school when they tried to return, well, we understand they overdid it probably, but if they're getting worse, we don't understand why. That's one that would be a good reason to refer. If they've had multiple concussions over their lifetime, they may have a more complex recovery pattern, and the return to sport decision-making process becomes a little bit more cloudy. And so sometimes there are consideration from retirement from contact sports, even if that's their first injury, and now they're 6 months out from their first injury, and we're trying to decide, does it make sense for them to go back? And some people talk about numbers of concussions, and I don't think there is a clear number. In the past, people have used the number 3. Now, certainly nobody thinks it's a great idea to have multiple concussions over your lifetime. There may be some cumulative sequelae of this, but those are good reasons to have consultation with a specialist, and to have that decision made with you and somebody else as opposed to on your own. To help us conduct research on this patient population, we are at Scottish Rite happy to see any patient when they're calling or presenting, even initially for a concussion. Go ahead. We like to get involved early on, help them with that return to learn and early management, getting them back to activity or sooner. So to summarize some of the guidelines from the CDC, these are the top 5 take-home points that they want readers to get. Again, do not routinely image patients to diagnose concussion. Use validated symptom scales to diagnose a concussion. Assess evidence-based risk factors for prolonged recovery that we just discussed. Provide patients with instructions on return to activity customized to their symptoms, and counsel patients to return gradually to non-sports activities after no more than 2 to 3 days of rest. So again, the key concepts of not getting a CT on everybody and trying to get them back to activity sooner than later is likely helpful. The AAP went through similar concepts. Neuroimaging is normal. Initial reductions can be beneficial, but prolonged restrictions may be detrimental. One concept that we didn't really discuss would be long-term effects of a single concussion or multiple concussions has still not been conclusively determined. There is certainly concern about this concept of CTE, or chronic traumatic encephalopathy, that we still have a lot to learn, but there is emerging evidence that repetitive blows to the head over the course of a lifetime may have detrimental long-term effects. And so, of course, anything we can do to reduce the risk of that makes a lot of sense. Let's see. Athletes with prolonged symptoms should be evaluated for coexisting problems. Again, I mentioned, for example, a cervical strain. That may be causing them to not recover and cause their headaches, but it's actually the concussion is recovered. And so here are the references that I primarily utilized today, in addition to the concussion consensus statement, the 5th consensus statement there on the top right, the CDC, the AAP, and the AMSSM guidelines, further references. And so we look forward to having you hopefully come in person to an upcoming Coffee Kids and Sports Medicine presentation. Here is our campus in Frisco. And if not, certainly look forward to welcoming you online to future sessions. So I thank you for your time and attention, and make sure you complete the post-test so you can get credit for this if you are looking for the continuing education credit. Thank you.